Hello everyone, my name is Larry Rower and I'm going to talk to you about the organizational problem I focused on this semester at my practicum site. The problem I wanted to help solve revolved around patient falls in the organization. As you can see here by this graph, the falls data within the organization remains high and it has hit record levels. This remains despite the tremendous attention this nursing sensitive indicator receives from nursing leadership and trickling down to the unit level. To address the issues related to patient falls, a variety of quality improvement projects have been attempted. These include making changes to how patients are assessed for being a fall risk, to modifying the electronic health record, making it easier to identify who is at risk for falling. Lastly, education has been provided to all nursing and ancillary staff to reinforce these behaviors. This graph illustrates specific reasons that patients have fallen in the last month. This has been a consistent trend month after month, and it clearly illustrates that patients are not calling for help, and it is the precipitating factor leading up to patients falling, which could be prevented if proactive patient rounding was occurring on the units. About 50% of all those falls occur for that one reason. The goal of my project was to implement proactive rounding, which has been difficult to do at my practicum site. It has been tried for several years without success. The overall goal is to reduce patient falls, but proactive rounding has been shown to have a variety of other positive outcomes. For example, research has shown that as a result of proactive rounding, patient satisfaction and HCAHPS scores will also improve. It can also decrease patient call bell usage, allowing staff more time to care for their patients. Proactive rounding is not the burdensome task that the staff perceive it to be. The table on this slide is a step-by-step process used in a study by Mead et al. On how they conducted proactive rounding on their units. Having a standardized process will help ensure a consistent practice among staff. As part of this project, SMART goals were created for both process and outcome measures. A 20% decrease in patient alarms over 6 months is not a stretch, as one study by Coley showed results with reductions of 30 to 70% after proactive rounding was implemented. Based on the volume of alarms for this one unit, the goal is to reduce the number of alarms from 400 a day to 320. Proactive rounding has also shown that it can reduce patient falls, but this is a secondary outcome, as the goal is to institute proactive rounding. The resources needed for this project were minimal. The technology already exists, it was just never used to its full potential. One thing that is needed is a true commitment from nurse managers and directors to ensure that this process becomes fully implemented into nursing practice. Many managers I spoke to about their process did not put this anywhere near the top of their priority list. The only thing that is needed to help ensure this is a successful implementation is creating a process so that everyone knows when a patient was rounded on, without adding anything new into the electronic health record. The initial plan for this project was to create a process to ensure and monitor that proactive rounding has occurred. This required use of personal tracker devices that work in conjunction with the call bell system. Using this data at an individual level did not have a positive reaction from the staff, nor did it promote their willingness to change their practice. Instead, they became defensive and came up with many reasons why the data that was generated was inaccurate. I quickly realized that this was not the approach to take in order to be successful with this project. Instead, we changed the focus of this project to show the staff how proactive rounding will impact their work environment in a positive way. Data was presented to the individual units about the type of call bells that occurred. I used the unit shared governance structure and tasked them with creating the process of doing proactive rounding instead of providing them with a script and dictating the process to them. I did, however, provide them with examples from the literature that has shown to be successful. One example, a med-surg unit developed a process where the nurses round on patients on the odd hours and the aides on the unit rounded on the even hours. While I am unsure whether this tactic will work, it is different from previous attempts at rolling out proactive rounding. There are a number of ways to evaluate the success of this project. Continued monitoring of call bell usage is the first step, as there is an expected reduction in alarms. The next way to evaluate success is by monitoring the monthly falls rate, as this is identified as the organizational problem. Lastly, monitoring the HCAHPS scores that are impacted by proactive rounding will be important too. These include questions related to how quickly call bells were answered, or how quickly you were able to go to the bathroom, as they are specific to this process. This graph shows the number of call bells on a single med-surg unit over the course of 7 days. Normal call bell usage alone accounts for 1,618 alarms, which averages out to be one alarm going off every 6 minutes, 24 hours, 7 days a week, and does not include the other 46%. To look at this data another way, if it takes 2 minutes to answer every alarm, they are spending 100 hours during this week to respond to these nearly 3,000 alarms, or 14 hours a day. This data can be displayed for staff to see and compare how they were doing from week to week. The same unit's data is displayed here with weekly totals. This unit had already been trying to reinstitute proactive rounding onto their unit early in the semester. The first 4 data points are random weeks pre-implementation, and the last 4 points are post-implementation. The trend line displayed shows a 16% reduction in alarms post-implementation. Unfortunately, further analysis as the semester went on did not show sustainability in this trend, which has caused the unit to look at other avenues for embedding proactive rounding into their practice and holding their staff accountable. When the semester is over, the units can continue to monitor their results and tweak their process as needed. The best method for doing this is to use the Plan, Do, Check, Act process, which allows for rapid quality improvement. Every unit has their own PDCA board. Making proactive rounding and patient falls the current PDCA project will showcase to the staff the importance this nursing sensitive indicator has to the unit. Using the unit call bell data allowed me to show the staff that there is a return on investment for them to do proactive rounding. They will have less alarms, which gives them time back to spend with their patients. Also, they are addressing the patient's issues at the nurse's convenience and not at the patient's demand. During the planning stages, the leader is responsible for identifying the problem and determining ways to solve it. In this case, those questions were already answered, but it was how to get the staff on board with the solution. Before working with staff, it was necessary to be aware of the barriers they perceived and have solutions ahead of time. Lastly, it is important to understand their point of view and seek their input because they are the ones who are doing the work. And you need to have their buy-in and willingness to make the change in order to be successful. During the implementation phase, the leader needs to be transformational and inspire a clear vision that the staff can accept. Leaders need to engage the staff in the process at each stage and identify and involve nurse champions so that they can model the work for their peers. This ties into the theoretical framework used for this project. As for the evaluation phase, it was not completed during this course, but the process to compile and display the data was created for continued monitoring at a later date. There were 2 theoretical frameworks I used in this project. The first is Ozgen and Fishbein's theory of reasoned action. This really looks at the staff's perception or attitude and willingness to do a behavior. I was able to use this framework to tweak my project and focus on the call bell usage instead of individual performance. The latter only had the perception that they would be punished for not doing something, whereas the new approach will display a positive overall result. Also, as I mentioned earlier, the theory of reasoned action also incorporates peer interactions, which is why champions are so vital. If the staff see others role modeling behavior, others will follow their lead. I was also able to use components of Kurt Lewin's change theory framework. Again, I changed focus from an individual view of how work was being done and focused more on the overall system and looking at the unit as a whole. The individual behaviors will impact the unit's overall performance. What made this framework ideal is that the unfreezing, change, and refreezing approach would stop the prior nursing practice from occurring and move forward with new practice of proactive rounding. As the semester comes to a close, I finish my project in the middle of the change phase of Lewin's theories. In summary, patient falls remains a big problem at the organizational level at my practicum site. It has not been easy to implement proactive rounding into practice, as staff still have pushback against making this change and do not feel that it is value added. It will take longer than these 15 weeks for the organization to fully implement this into practice and show significant results with call bell usage, patient falls, and patient satisfaction scores. The lessons I have learned doing this project is that first you must be flexible. I went into this course ready to do this project, but found that I had to make changes along the way in order to find success. Also, it is possible that what I have done is not the solution, and it might take many more interventions to be successful at reducing patient falls. Lastly, as a leader, you have to be ready for the possibility that you will not be successful. You must be willing to accept that and not let that stop you. To finish out my presentation, here are a list of my references. Thank you, and I hope everybody has a great semester.